Hi, I'm Dr. Hamid. Today we will discuss about hypercapnia and COPD patient induced by oxygen supplementation. This is an important concept we usually tested on board exam, especially UCMLE. So first we will discuss about normal respiration in our body, then the central and peripheral chemoreceptors. We will discuss about COPD patients and then how the supplementation of oxygen induce hypercapnia in COPD patient. Normally we know respiration consists of two parts: inspiration, in which oxygen is inhaled, while expiration, in which carbon dioxide is held. The rate for normal respiration in adult is about 12 to 20 beats per minute. So there are some pathological and physiological conditions in which the respiratory rate can change, that can increase or decrease, and this change in the respiratory rate cause a change in the ventilation. So which called hyperventilation or hyperventilation, and these changes are in order to compensate for the increased carbon dioxide or decreased oxygen level in the body. Now, the chemoreceptors which play an important role in controlling the respiratory rate are the peripheral chemoreceptors and the central chemoreceptors. The peripheral chemoreceptors are present in the carotid and aortic bodies. These are sensitive to changes in the arterial partial pressure of oxygen, while the central chemoreceptors present near the respiratory center and the medulla are sensitive in changes to arterial partial pressure of carbon dioxide. But the most important factor which contribute and drive the respiratory rate is the carbon dioxide, which are sensed by the central chemoreceptor. So normally we can say that the central chemoreceptor play a major role in increasing or decreasing respiratory rate in response to increase or decrease in carbon dioxide level in the arterial blood. So how the changes in respiratory rate occur? When there is increase in carbon dioxide level, this is sensed by the central chemoreceptors, which cause hyperventilation and attempt to exhale the maximum carbon dioxide. So when the carbon dioxide normalize, the respiratory rate decreases. Similarly, the respiratory rate can also be affected by the arterial pressure of oxygen, but until it drops to 60 to 70 millimeter of mercury. It's COPD patient, we know that there is chronic inflammation of the airways in the alveoli, and because of this chronic inflammation, there is obstruction of the airways, which result into carbon dioxide retention because the patient cannot exhale properly. The other phenomena is that the damage to the alveoli result into decreased surface area for the diffusion of oxygen and carbon dioxide. So because of this damage, there is a decreased oxygen diffusion into the blood, and there is decreased diffusion of carbon dioxide from the blood into the alveoli. So the carbon dioxide level in the blood increases, and because of this defect damage, there is chronic hypoxia in the patient. And in response to chronic hypoxia, we know that the pulmonary vessel constrict, and this pulmonary vessel constriction is actually a compensation to divert the blood from the damaged alveoli or damaged part of the lung into the well ventilated areas of the lung in order to improve the ventilation perfusion ratio. The mechanism So these three basic mechanism causes are increase in carbon dioxide level in the body. Now this increase in the carbon dioxide level in COPD patient is sensed by the central chemoreceptors initially, and it increases respiratory rate in order to exhale maximum carbon dioxide. But as the disease progress and it is a chronic disease, the central chemoreceptors become insensitive to carbon dioxide level. It means that with time, the increase in carbon dioxide level in COPD patient is not properly sensed by the chemoreceptors. We also studied that in COPD patient, there is chronic hypoxia in which the oxygen level usually drops up to 60 to 70 millimeter of mercury. When the oxygen level in COPD patients drop up to 60 to 70 millimeter of mercury, it is sensed by the peripheral chemoreceptors, and now the the key player which drive the respiratory rate diverts from central chemoreceptors to the peripheral chemoreceptors, and now the peripheral chemoreceptors drive the respiratory rate. So the drop in the oxygen arterial partial pressure, it is sensed by the peripheral chemoreceptors, and it directs the respiratory center to increase the respiratory rate in attempt to exhale maximum carbon dioxide and inhale maximum oxygen. So in COPD patient, now the phenomena is changed. Again, I will repeat that in COPD patient, the respiratory driver change from the central chemoreceptor to the peripheral chemoreceptor. Now, when oxygen is given to a COPD patient, what happens is that the arterial partial pressure of oxygen rises. Previously, we studied that the drop in the arterial pressure of oxygen is the main driver for the respiratory rate in COPD patient. Now, when we give oxygen to a patient, its arterial pressure rises. It means that we are removing the stimulus for increase increasing respiration or increasing respiratory rate. So when we remove the stimulus for the increasing respiratory rate, what happens? The respiratory rate drops. There is a drop in the respiratory rate. So at the drop in respiratory rate means a decrease in the alveolar ventilation, and it means decrease carbon dioxide exhalation, and it's mean that there is retention of carbon dioxide. So this is one mechanism in which oxygen causes retention of carbon dioxide in COPD patient. Another mechanism which cause increased carbon dioxide retention in the body of COPD patient is that when we give oxygen to a COPD patient, it causes pulmonary vessel dilation, because we know that hypoxia causes pulmonary vessel contraction. So when we give oxygen, the hypoxia is removed, so the pulmonary vessel dilate, and by the pulmonary vessel dilate, there is a distribution of the pulmonary blood to the all segments or the all parts of the lungs. Redistribution to all parts of lung, which also include the damaged alveoli which cannot diffuse oxygen or carbon dioxide. So it's mean that the blood is shunted again from well ventilated area to the areas which are not well ventilated, and there is a defect in the ventilation and perfusion. So it results into decreased ventilation perfusion ratio, and it then decrease carbon dioxide diffusion, and it cause retention of carbon dioxide in the body. So this is another way in which oxygen supplementation causes retention of carbon dioxide in COPD patient. The third mechanism which causes carbon dioxide retention in COPD patient, that we know that in hypoxia, the hemoglobin affinity, hemoglobin is increased affinity for carbon dioxide, for carbon dioxide. So in COPD patient, when there is a hypoxia, there is increased hemoglobin affinity for carbon dioxide. It means that the carbon dioxide will be taken by the hemoglobin. It will be delivered to the alveoli, and it is then expired in the air by expiration. But now when we give oxygen to a COPD patient, there is increased affinity of hemoglobin for oxygen and decrease affinity of hemoglobin for carbon dioxide. So now this decreased affinity of carbon dioxide mean that now the hemoglobin will not be able to carry that amount of carbon dioxide to the alveoli which it was previously carrying. So because of this decrease in affinity of the carbon dioxide, there will be increased carbon dioxide in the tissue. So this is another way in which carbon dioxide is increased in the body. So these are three mechanisms which cause carbon dioxide retention in COPD patient by supplementation of oxygen. So in nutshell, we can say that oxygen supplementation in a COPD patient can cause hypercapnia, which means increased carbon dioxide in the body, by three mechanisms. Number one is due to insensitivity or decreased sensitivity of central chemoreceptors, which affect the respiratory rate. The second one is the pulmonary vasodilation, which divert the blood from the well ventilated regions to the improperly ventilated regions. And the other one is decreased affinity of hemoglobin per carbon dioxide, which results into decreased transport of carbon dioxide from the tissues to the lungs. So